with another differential of lymphoma need to be considered, as well as splenomegaly. So they did a core biopsy of the left anterior chest wall. It turned out to be atypical lymphoid proliferation with a positive CD20 diffuse positivity and high proliferative index Ki67 about 80%. So the diagnosis of lymphoma need to be considered. Subsequently, she presented with superior vena cava obstructive symptoms, and another CTTAP urgent was performed, which shows similar findings as the first one with the enlarging lymph node and hepatosplenomegaly. Otherwise, the biochemical parameters show raised LDH 390. So they sent left axillary mass for HPE, and it turned out to be diffuse large B-cell lymphoma, ABC subtype, with dual expression of CMYC and BCL2. This is a patient full blood count serial showing mild to moderate anemia, hypochromic microcytic with increased WBC, predominantly lymphocytosis, and normal platelet count. The CAMPATH biochemical parameters show normal liver function test with renal function show a bit of AKI picture and raised LDH. And the tumor lysis marker parameters are not increased. So I show the FBT slide first. Can see the smear.
Yeah, okay, but lighting not so bright. Better now.
Okay, I continue. So this is the MVP that we got. Under low power view, we can see the red cell morphology is hypochromic microcytic red cells and a bit of anisopodylocytosis with presence of elliptocyte. Okay, and then when view the WBC, we can appreciate there is increase in WBC with lymphocytosis.
Absolute lymphocytosis. Yeah.
Absolute lymphocytosis, and the Morpho wise, the lymphocytosis composed of mature looking lymphocyte.
Many smear cells, huh?
Yeah, many smear cells. This one also another mature looking lymphocyte with clump chromatin pattern and inconspicuous nuclear line with pale moderate amount of cytoplasm.
Tak ada benda ni.
There is no leukoerythroblast
Dia tak
picture
adjust
from
dia punya
the
microscope.
FDG.
Dia tak adjust microscope dia.
Okay. Another 3 mature looking lymphocytes here.
A lot of artifact. I think I don't know whether your microscope has been serviced.
The glue.
Oh, I see. Okay.
Sorry for that. Okay. Right, I think I can move to aspirate.
Okay.
So aspirate here. This is 68 years old. The fragment is hypercellular and of cell trail, I think a bit more hemodiluted compared to the hypercellularity of the fragment.
Cannot hear you.
Okay.
Okay.
For the cellularity, for the fragment cellularity, this is 68 years old, so hypercellular fragment.
Indeed.
The cell trail, I think, will be more the hemodiluted as compared to the hypercellular fragment.
Mm.
Okay, zoom in. Okay, when zoom in, the cells, I think we counting around 37% of lymphocytes, in which they have around similar morphology as the peripheral. Here,
I suppose the smear cell you don't count lah.
yeah, yeah, we don't include the smear cells into the NC count. So we can see that the lymphocyte here, actually looking as well, is a clump chromatin pattern and inconspicuous nucleoli. And when we browse through all the smear here, there is no abnormal large lymphoid cell.
All small cells, huh?
All small cell.
Small lymphocytes.
Yeah.
Or small lymphocytes. Okay.
Small abnormal lymphoid cell.
Mm.
Okay. Yeah, there is no large cell.
Something like CLL or well-differentiated lymphocytic lymphoma.
Yeah, the possible differential at the moment will be the small cell, either CLL or mantle also can be. Right. Can I share the flow?
Hemopoietic function seems to be quite good, huh?
Yeah.
Megakaryocytes are present.
Yeah.
The other elements like
is
granulocytic, okay.
Prof, can I move to flow?
Yeah, sure. Now we will be interested to know this target population of lymphocyte. The flow is peripheral blood or bone marrow?
Aspirate from the marrow aspirate.
Aspirate, okay.
Okay, so this is the flow cytometry performed on bone marrow aspirate, as our POI here gated at the high, moderate to high side, bright CD45 with low to moderate side scatter, and our POI is CD19 positive. From this tip, CD19 positive. And then for another screening, LPD show that the CD19 positive cells is showing the kappa restriction. Yeah, sorry.
Yeah. So it's clonal lah. These lymphoid cells are all clonal.
Yes. Yeah. And then our population of interest show negative for CD56 and negative for T marker CD3. Right. So we proceed with BLPD panel. It shows that our POI population of interest is negative for it's a bit dim, positive but dim CD5, positive for CD20, and positive for surface immunoglobulin. Surface IgM.
IgM.
Surface IgM. Okay, and then the next BLPD show that our POI is negative CD200, negative for CD38, and negative for CD23.
Okay.
Okay, as well as FMC7 also negative.
So essentially it's 19, 20.
Positive for B marker 19 and 20, and then CD5 positive and negative for 23, 200, FMC7, and 38.
Okay.
All right. So this one positive for CD22.
CD22, yeah.
Okay.
Right.
And yeah, so from the immunophenotyping analysis show there is 24% of abnormal lymphoid cell located at CD45 positive and those at scatter. So they are positive for CD19, 20, 22, positive for CD5 but dim, surface IgM and with the kappa light chain restriction. And they are negative for CD3, 56, 10, 23, FMC7, 200 and 38. Okay, so impression, so the abnormal lymphoid cell is consistent with the CD5 positive DLPD. The differential will be mantle cell lymphoma. Okay.
Okay.
Show the refined biopsy. So we, for refined biopsy, we received 2 strips of core biopsy. For the age, this is hypercellular.
Yeah, it's very.
It's very hypercellular. And from this low power view, we can see there is infiltration that forming nodules
Yes.
at the central as well as the at interstitial paratrabecular area as well as interstitially. Okay, when zoom in, the cells look quite monomorphic with small size, plum chromatin pattern, and yeah, inconspicuous neutral line. Okay, I show you the IAC. So this is CD20. CD20 positive for the cells, and the size of the cells you can see here small. Okay.
Nodular.
Yeah, nodular pattern. This is CD3, and we can see the CD3 highlights scattered positivity of the T cells, and the CD20 is more than CD3, so indicate that the one that highlighted is reactive T.
Yeah, more like reactive pattern. Yeah.
Yeah. And then this is CD5. CD5 also follow pattern CD3, and yeah, basically the CD5 here, I think it's follow pattern CD3, and you can see by IC is negative. So from the flow, we get CD5 positive, and then the differential diagnosis that needs to be excluded is follicular lymphoma. So this is CD10 negative for the cell.
These are reticulin.
This is CD10.
Wait, CD10. Oh, the CD10. I thought like it's a reticulin state. No, it's not reticulin. Okay.
Okay. So negative CD10. We send cyclin D1 to confirm.
Cyclin. Is it cyclin?
Cyclin D1.
Cyclin D1. Okay.
Confirm the mental.
Penting
Positive.
Positive
Positive for the nodules.
for the nodules. Okay.
Our interest is the nodules.
Okay, yeah. Not that fantastic lah.
Yeah.
Only some cells are positive.
Okay, we also send SOX11 But however, the SOX11 is only scattered positivity in the nodules. So it's quite inconclusive to be interpreted.
Okay.
Negative.
So SOX11 is a highly specific fermenter, right? Okay, and then I show the KI67. So KI67 inside the nodules here is around 5 to 10%.
Not very proliferative. The other immune cells are more proliferative. Other cells are more.
So it shows that this is low-grade lymphoma.
Okay, agree.
In correlation with the morphology from the FBP, from the aspirate, you can see that this is small cell LPD, and with the CD and positive for the B marker, with the positive for CD5, and cyclin D1 also positive, with a low proliferative index, evidenced by KI67 5 to 10%. The diagnosis suggestive of favoring mantle cell lymphoma.
Okay.
It's different with the tissue HPE, which show high grade the LBCL. So for the discussion part, the cytogenetic analysis for this patient is normal.
Cytogenetic. Cannot find anything.
Okay, for the discussion part, I'll discuss about the discordant lymphoma.
Okay.
So it defined as present two distinct histologic subtypes that coexist in at least two separate anatomic sites. And usually the discordant that most commonly observed between marrow and lymph node, where the lymph node usually show the aggressive lymphoma and indolent in the bone marrow. And this is not uncommon. It's about 10 to 15% cases of the LBCL. We found the indolent bone marrow involvement. Okay, and those patients with the discordant indolent bone marrow involvement and the patient with DLBCL, they show it has not been associated with increased risk of CNS involvement or relapse. So those patients that without high risk features, the monitoring, CSF monitoring is not really needed. Okay, and then interestingly, patient with the discordant lymphoma, they had no significant impact on the survival, even when accounting for the IPI score. Compared with the concordant histology, they have inferior overall survival, independent of the IPI score. Okay, a bit about the terms for the histology concordant versus discordant and in relationship with the clonality study. So when we have a lymph node biopsy that show infiltration by the high-grade LBCL and the bone marrow show indolent lymphoma, and the clonality study is not related, so this is what we call as discordant histology. And if the lymph node show infiltration by the LBCL or high grade, and somehow bone marrow show not indolent type of infiltration, and there is clonally related by the clonality study. So this also we call discordant histology. Okay, and if lymph node and bone marrow show the same infiltration by the same high grade lymphoma with the clonality study is related, so this is what we call concordant by histology. In terms of therapeutic approach for the discordant lymphoma, so basically the reasonable, ideally we target the aggressive LPD to be treated. For example, in the LBCL, we give R-CHOP. Okay, I think that's all from me, Prof.
Okay, thank you very much. So now you have to tell us whether this one are they of the same clonality, the two different morphologies?
Because the cytogenetic is not found is normal. So I'm not sure whether
They
they
did some study on the CMIC, isn't it? CMIC as well as the BCL2, wasn't it? I saw the report. In the histology, lymph node histology, I think it was reported, isn't it? Showing
yes.
a CMIC
Mm-mm.
as well as BCL2 mutation. Did we send, or did you all send the bone marrow for also the genetic mutation?
Unfortunately, patient already passed away before the
Oh,
result,
okay.
before the experience or the treatment series.
Yeah, is there any way? So you won't, because if you have not compared, then it's difficult, isn't it? Is in terms of marker, is there? Of course, markers are different lah. Markers are different lah. So the only way to mention whether they are clonally related, right? Like you mentioned in the classification, clonally related. Although it's discordant histology, wonder whether they are clonally related. So as you see in the lymph node histology, which is aggressive type, showing CMIC as well as BCL2, so so-called double hit lymphoma, right? So wonder whether the bone marrow finding, the low grade one, will also show the same genetic mutation. In that case, it will be clonally related lah. Otherwise, it will be clonally unrelated. So this is something we can't establish. Yeah, very interesting case today. Yeah. So it's actually quite common. This is not a common thing happening, but common in the sense that usually in discordant, we often see actually in the bone marrow is a low-grade lymphoma, whereas the lymph nodes show a high-grade lymphoma. So the implication what it means is that, the low-grade lymphoma probably have been around the patient or in the patient for some time. Then later on, the patient actually experienced this transformation to a diffuse large cell lymphoma, and that therefore resulted in this kind of discordant findings. Yeah. So this is very, very typical lah. Yeah. When you encounter this type of phenomenon in your practice. Yeah, maybe we can open up to comment. Anybody see similar case in their center? I think we have a number of presentation along this line previously also lah. So in this case, it's more like low-grade mantle cell in the bone marrow, whereas got a high-grade double hit lymphoma in the peripheral, in the peripheral nodes.
Sorry, Prof. Prof. Cheong, I'm Shira from
Yes,
HTC. I would like to ask whether can we proceed with CMIC and BCL2 in trifine biopsy to see the and can we relate that as for their clonality?
That will be good for publication if you can do that. Yeah, good idea. Yeah, maybe still got the trifine. Maybe ask them to go and do genetic studies. Yeah. The block should be able to do. Yes, I forgot. Yes, yeah. Blood smear will be difficult lah because you have to scrape it. I'm not sure whether you still got remaining slides, you see. But the trifine block should be okay. Yeah, they got all you need to cut some section and send it. They don't require too much of DNA to be extracted, and then they can amplify the thing. Yeah, good suggestion. Maybe the UKN team can consider. Then once you get the result, then you can actually do a very nice case report. Very nice case report to add to the literature the number of this kind of discordant lymphomas found. Okay, so if there is no further comment from the participants, maybe we can proceed to the second case.
Hello.
Yes.
Okay. Good evening, Prof. Cheong. And everyone. Today I will be presenting another morphology case for pediatrics. So this case, okay, my name is, by the way, Nur Aisha. So this case actually was referred from other private center to our center. This is a case of 8 years old boy with underlying Crohn disease, referred from private hospital to route HLH. Initially, he presented with prolonged fever for 2 weeks and lethargy with bicytopenia, mainly thrombocytopenia and anemia. Otherwise, no loose stool, no other bowel habit, no cough or runny nose, no vomiting, no bleeding tendency. And on examination noted, during that time, patient have new onset of thrombocytopenia with chronic anemia. Previously, patient has history of multiple admission to the private hospital because of anemia. And during that time, they commented as iron deficiency anemia. Serial blood investigation was taken at admission in private hospital. Noted there was increase in ferritin more than 15K, low fibrinogen, 1.3 gram per liter. Clinically, on examination, noted no hepatosplenomegaly. Fasting triglyceride during that time was normal, 1.1. At private hospital, they completed IV antibiotic and was transferred to HPKK UKM for further management as symptom was not improving. So at our center, repeated blood investigation showed worsening increase of ferritin and CRP with severe pancytopenia, normal fasting TG, transaminitis, and low fibrinogen. And during that time, on examination, noted patient have hepatosplenomegaly, no lymphadenopathy, jaundice, and patient have on and off bouts of spiking temperature at ward. So during this time alone, from the clinical point of view, they were suspected that this patient was having HLH, and they referred to us pathology for bone marrow to see for hemophagocytic activity. So at our site, we did bone marrow, and I show you the morphology.
How come the private hospital, they cannot do bone marrow? I have to refer to UKM.
Actually refer to us for worsening symptoms lah. There was no.
Okay, to manage the whole case, transfer too expensive already.
So this is the full blood picture of this patient. So as we can see here, for the RBC morphology, so it's like patient looks dimorphic because during this time
Transfuse,
already transfused lah in private hospital. And also there is presence of hypochromic microcytic red blood cells, and you can see there is polychromasia. Okay. And then for the white blood cells, there is increase in neutrophils count. Okay. So and for platelet, actually patient have low platelet counts lah.
Hardly any platelet can be seen.
Okay. So during this time, patient got bleeding tendency lah because of the low platelet count.
The patient also got lymphopenia, is it?
Lymphopenia.
Not many lymphocytes can be seen. Most of them are all neutrophil. When you slide around, shift around the slides. Don't seem to see lymphocytes.
I think this one patient have neutropenia, but lymphopenia, no, Prof.
No,
Wait. Because I don't have the count with me.
I see. Okay. Because as you move the slide, I cannot see any lymphocytes.
Actually, sikit lah. Predominantly we see in product picture is neutropenia. So we proceed for the bone marrow.
Okay.
So for this patient, he is
8 years old.
boy. So we can see in the fragments, it looks patchy hypercellular.
Yeah, very packed also. Hardly any fat space.
Yeah, some area yang noted increase in fat spaces, but most of it, the fragment shows hypercellular with cellular cell train. So the ones,
Got mega or not?
yes, mega is quantitatively adequate. But some of them shows hypolobation and widely separated nuclei.
Yeah.
Because we have to search for the hemophagocytic activity, so actually I mark the
Yeah, because it's a refer case to, to sort of exclude HLH. Yeah, suppose you have to search for it to see whether it's present now.
So this one you can see.
Oh, this one is mega, is it?
This
No,
is
it's not mega lah.
This is actually histiocyte engulfing the nucleated RBC, the area, and I think this one is some of the dying cells.
Yeah.
You can see it very clearly engulfing the area.
It's a macrophage, all right lah. Not that common, huh? You have to look for it.
This one you can see
see another macrophage there.
It was engulfing the surface.
Greedy, eaten the metamyelocyte.
I want to show that some of them are also engulfing more of multiple area inside, but I cannot find it.
Yeah.
This one actually also engulfing the, I think, multiple area lah. This one. Actually, there are quite few numbers of
Is this a mega or macrophage?
Macrophage.
You think so?
Eating the macrophage are eating the, I think, 2 areas.
Oh.
You're right. So for the, also in the bone marrow, we conclude as macrophage are easily seen, and there is increase in hemophagocytic activity exhibited by histiocyte you can see it engulfing the normal hematopoietic cell as the NRBCs and granulocyte. And we can see some of the histiocyte actually are engulfing single cell and some are engulfing multiple nucleated cells.
Okay.
So, but within this marrow, we don't find any evidence of acute leukemia, lymphoma, or non-hematopoietic malignant marrow infiltration. So we did the trifine for this patient. We did flow for this patient also is suggestive of no evidence of abnormal blast cells or abnormal lymphoid population seen in a flow. So for trifine, we received for biopsy in single slide. So we receive an adequate length of marrow, marrow spaces, bony trabecular, and also we can see for this patient, 8 years old, the cellularity is hypercellular. Okay. But here we can see the histiocyte.
Much better.
So you can see there is a lot of histiocyte here, interstitial. But we don't see any abnormal lymphoid cells or eventual cells within this population, within this refined biopsy.
There's a lot. It looks like there's some increased fibroblastic reaction. Is there a reticulin study on this?
Actually, reticulin was not done.
They don't routinely do unless you request.
Yes.
Yeah. I was wondering why you see so many macrophages, in the trachea, and yet in your aspirate, you have to go and mark it and look for it. What happened to it? So one of the logical explanation to me is probably they got held back when you aspirate. You held back by fibrous tissue so they are not released in your aspirate. You see, that's why you can see so easily see the macrophage or histiocytic proliferation within the trachea, and yet in the bone marrow you have to search hard for it.
Yes. Okay.
All right. Okay. So can you see the phagocytosis in the bone marrow in the trachea?
Yeah.
Can also. Sometimes not easy.
I think this one actually we send for CD. This marker we send for CD, CD3, CD79A, and also CD68.
Okay.
However, no abnormal lymphoid aggregate seen. The CD79A actually only highlighted reactive B cell. Wait, it was scattered. No.
So there is no clonal B cells or clonal T cells seen.
Then and then for CD3, scattered also.
Scattered. It's not sort of aggregates. It is always important when we see hemophagocytosis in the bone marrow. We need to actively exclude any secondary causes like metastasis, lymphoproliferative disease, things like that. Yeah.
So here we can see the CD8 immunostaining highlighted the histiocyte with elongated dendritic cytoplasm.
What is this stain?
CD68.
68. Okay. So it's going to highlight the macrophages.
Yes. So we can see there is increase in CD68 as highlighted by the microphone.
Strong,
Okay. So for this patient, we conclude as defined biopsy shows evidence of SLH with no excess of blast seen.
Okay. So the next question to ask is actually whether it is primary or secondary. Yeah.
So for this patient, actually they send for all the effective screening. It all turns back as negative.
All right. Yeah.
So this patient was actually having underlying Crohn disease, was on steroid for quite a long time. So might be that this can be the one of the causes that leading to the HLH due to the immunosuppression.
Yeah, there's a possibility here because because we know that HLH is also associated with autoimmune disorder or immunosuppression. So therefore, wonder there's a possibility also lah.
So for this patient, actually, due to the severe, his worsening got worsened, and have a bleed, complicated with ICB, intracranial bleed due to severe thrombocytopenia.
Mm-hmm.
And unfortunately, this patient succumbed lah.
Oh, okay. Most unfortunate.
And we are treating him with chemotherapy during his admission at our center.
Ah,
So, so
Impact
for
also.
my part of discussion would be more on morphological part instead of the clinical part. So we know that HLH is a very life-threatening syndrome that occurs secondary to severe systemic immune activation, and cytotoxic T cell proliferation lead to increased cytokine production and activation of tissue resident macrophage, which causes increase in hemophagocytic activity, as we see. So for diagnostic criteria for HLH, as per HLH 2004 protocol, they conclude that the diagnosis of HLH can be established if either one or two below is fulfilled. First is molecular diagnosis consistent with HLH, and second, if there is fulfillment of 5 out of 8 clinical criteria, such as fever, splenomegaly, which is this patient have, cytopenia, hyper TG or hypofibrogenemia, hemophagocytosis in bone marrow or spleen or lymph node with no evidence of malignancy, and new diagnostic criteria established low or absent NK cell activity with high ferritin and soluble CD24 or soluble interleukin 2 receptor more than 2,400. So the presence of hemophagocytosis in the marrow fulfill one of the HLH 2004 diagnostic criteria. So we can see that actually the bone marrow histomorphological criteria will help the clinician in establishing the diagnosis of HLH. However, lack of evidence-based guideline lead to considerable uncertainty among pathologists as to what degree of hemophagocytosis is sufficient to satisfy this criteria. Therefore, one retrospective study has been conducted to assist pathologists in diagnosing HLH based on a bone marrow histomorphological criteria. So this was study done by Eric Gar. So he established the bone marrow histomorphological criteria that can accurately diagnose HLH in bone marrow. So we can see from this study, this come out conclusion that hemophagocyte ingesting granulocyte was chosen as the most important predictor of HLH, followed by NRBC and lymphocyte. And usually patient with absence of hemophagocyte ingesting granulocyte had a 3% chance of having HLH diagnosis, compared with the presence of at least one hemophagocyte with an ingested granulocyte, two or more hemophagocyte with ingested NRBC, and one hemophagocyte with ingested lymphocyte can guarantee that this patient have 100% chance of HLH diagnosis. So identifying lymphocyte was quite high in hemophagocytic cells, and it is even rare. So the study said that 92% chance of having HLH diagnosis will be established when there is presence of at least one hemophagocyte with an ingested granulocyte and two or more hemophagocyte with ingested nucleated RBC, which we see in this patient bone marrow. So for the qualitative evaluation of bone marrow histomorphological criteria, it says that presents at least one hemophagocyte containing multiple nucleated cell was demonstrated in all patients with HLH. Therefore, this finding may be indicative of a pathologic hemophagocytic state when we see one hemophagocyte ingesting multiple nucleated cells. So this is an example of hemophagocytosis in patient with HLH. So usually they said that histiocyte in patient with HLH often display rounded contour with cytoplasmic projection, and hemophagocyte can be present with single ingested mature RBC here, and either it ingests NRBC or we can see it ingested the granulocytes. However, in H, we can see example of histiocyte with degenerating nuclear debris, indistinct cytoplasmic contour, and equivocal intracytoplasmic nucleated RBC that we do not consider to be a definite hemophagocyte. Although we see that there is increase in this kind pattern of histiocyte, but it does not representative of definite hemophagocytic activity. So as a conclusion, HLH is a challenging diagnosis for clinician and pathologists. It requires thorough clinical assessment of patient apart from laboratory investigation, and microscopic examination of bone marrow aspirate smear in patients suspected of having HLH require careful evaluation for the presence of hemophagocytosis. So based on this study, it demonstrates that quantitative threshold of the lineage of ingested cell, either alone or in combination, can accurately predict the eventual diagnosis of HLH. So I think that's all from me. Is there any question?
Assalamualaikum, Nuraini. I'm Dr. Shira from HTJ. I just want to ask, have you done any special stain to exclude any bacterial or fungal, for example, in your 3-5? For example, have you done an stain, pus or grocott to see whether any fungal bodies or tuberculosis inside your 3-5?
For this patient, we didn't do the additional stain for the fungal.
Okay, next is whether they have excluded all the infective diseases in this patient or the secondary HLH.
Actually, they did. They already sent for fungal screening, EBV, PCR, and also infective screening. All turned back as negative.
Okay, thank you. I'm not sure. The next is to Prof. Cheong. My practice for secondary HLH cases, I will proceed with further stain, special stain to exclude any bacterial or fungal bodies. Would that be recommended, Prof. Cheong?
Yes, I think it is necessary when you want to find, whenever you sort of suspect a patient of HLH, invariably you need to determine yourself, you ask yourself, or other the clinician also will be interested for us to help them to see whether it is primary or secondary. So we will be actively looking for secondary causes. It depends on whether your center has the facilities, then you actively look for it. I suppose most of the clinician will be looking for secondary causes due to an infection, right? And of course, in the lab, if you have availability of special services like fungal stain, for example, you can actually incorporate in your treatment to look for it. Yeah. So I think practice vary in different centers. But at the end of the day, it's actually you have got a case of HLH, right? So you have to decide whether this is primary or secondary. So you will try to gather all the tools available in the hospital setup, in your lab setup to help you to determine whether it is secondary or not. That is one point. I think there's a person, Dr. Amansa mentioned about how to look for primary. So the other thing, of course, again, depends on whether we've got facility. So in primary cases, which can be familiar or sporadic, they have got genetic mutations. So if you got genomic services, or even you can actually buy those genomic services nowadays, then you try to look for the relevant genetic mutations associated with HLH. So that is another option if you got the money Yeah. So I think it's very interesting. I think in the old days, when I was in training, like you all, many of you, we are actually just saying that this is the original name is called hemophagocytic syndrome. right? Hemophagocytic syndrome in the bone marrow. Why syndrome is because it can be primary or secondary. That's why it's syndrome. And the characteristic of the syndrome is hemophagocytosis. But along the way, it become very complicated, right? And then, as you can notice, 2004, they actually, along the years, right? They actually forming society to study it and then forming criteria. It's interesting to note that in the last few years, you see publication coming out to say that, hey, despite with all the criteria, we sometimes we say that, you know, we don't have enough criteria to make the diagnosis. So at the end of the day, there are several reports like the one that is quoted just now, coming out to emphasize, at the end of the day, when they study all these cases, they will emphasize the key element is hemophagocytosis in the bone marrow, right? As being highlighted. And then now you can see people looking at, okay, how do they define hemophagocytosis? What is considered a hemophagocyte and what is considered not? Right? Typically, they say, oh, no, there's not hemophagocytosis. Right? You have to be intact cells. Right? So that's very interesting. You know, it's like history, you know. After from very simplistic hemophagocytosis to very complicated criteria, then come back to square one. Then say, hey, well, you show macrophages become very greedy you know. After buka puasa, eat a lot like that. Something like that, you know, you see how we have got changing practice and changing opinion of the day. So I think the take-home message for today is that if you want to determine HLH, the key feature is actually looking for a bone marrow, whether it's aspirate or trephine. So obviously, when you come to aspirate and trephine, aspirate may have limitation because if they get trapped in the bone marrow, they don't come out. You don't find anything. You cannot find those cells, you know, and then you cannot say, I'm not hemophagocytosis. So at the end of the day, oh, luckily I got trephine. Trephine will see them, right? And then you can stain them and identify the element, whether they eat neutrophil, they will eat, you know, all the other red cells or nucleated cells. Sometimes you just bare nucleus, you can't tell what cell it is. But surprisingly, it's very hard to find lymphocytes, even though, you know, we call it lymphocytic histiocytosis, and not much of the lymphoid component. But of course, on staining, you will find all these B cells and T cells present in the bone marrow. So it's very interesting observation. I think thank you very much actually for UKM team to present this case and highlight this the key element of observation. Morphology is still very important in making a diagnosis. Yeah. Okay, maybe we can hear what other people say. Any comment from participant? All right. If not, then thank you very much for this joining us in this session, and thank you for the host, UKM team, for presenting two beautiful cases. Right. Okay.
Thank you,
So for all our Muslim friends, happy Buka Puasa later. Right. Bye-bye.
Bye.